So without any delay, we'll start the presentation. I hope I'm audible. Mayur, am I audible perfectly?
Audible.
Hello?
Please, sir, you are audible and
Okay,
visible
okay,
too.
okay. So friends, topic for today's discussion is management of node negative neck, current trends and concepts. So what happens is, as you all know, that in oral cancers, the primary site of metastasis is neck, followed by lungs, and then the metastasis happens in whole body. So the being the first site, if you can control the metastasis there and there only in the neck, then you can very well control metastasis elsewhere in the body. So that's why management of neck is so important. What happens is, when you have a stage 3 or stage 4 disease, like the primary disease is very advanced, in those cases managing the neck is not a issue. I mean, it's a straightforward thing that if it's an advanced disease, you have to manage the neck. But when it comes to the smaller diseases, in those cases you have to actually think about managing the neck. Like, people get confused whether to manage or not to manage the neck in these cases. Somebody's mic is on. Please just turn it off. Thank you. So that's why managing the neck is very important. So for PGs, this will be the outline of today's talk. If this question is being asked in exam, this is how you can actually write the answer. So we shall be talking about significance of cervical metastasis. What are the controversies related to treatment of this entity? How we diagnose the N0 neck? Then electively treating the neck versus wait and watch approach. We will also be talking about sentinel node biopsy, extent of neck dissection, whether to manage ipsilateral or bilateral neck dissection. We shall also be talking about single node positive cases and quality of neck dissection. So, friends, the cervical metastasis, it becomes the most important prognostic factor. As soon as the cancer comes from mouth to neck, it immediately becomes the most important cause of mortality. There is a 50% decrease in the survival rate once you get a node positive in the neck, and that makes the cancer stage 3. And when the cancer comes out of the node, that is extranodal extension, that again reduces the survival by 50%. So that's why appropriate management of neck is paramount. Now, what are the controversies regarding this? First, there is no very accurate method of diagnosing N0. Obviously, when it's a node positive neck, it's easier to see. But when the metastasis is not very significant, in those cases, diagnosing N0 is not foolproof. There are many factors that dictate the neck metastasis. Like, there are many risk factors that can actually tell you that what are the chances of neck metastasis. And the treatment is, that is why, very controversial. Like, few people, they want to do neck dissection at the time of primary surgery, and few people, they try to do wait and watch. So that is the biggest controversy, and that have been recently actually resolved. So, like, what are the armamentarium that you have for staging the N0 neck? We have clinical examination, we have USG, CT, MRI, and PET scans, and we have sentinel node biopsy. That's a recent technology. So these are the things that we have in our this thing. And then clinical examination alone is inferior to CT scans, and that have been proven by this study by Merit and Associates. And you see that the CT scan is highly significant, better clinical modality for examination of neck nodes. Then there have been a study regarding comparison of the imaging technologies, like they have studied USG, CT scan, MRI, and everything, and they found out that USG guided FNAC was the most specific test, and it has high sensitivity also. So if somebody asks you like what will be the sequence of the imaging modalities in oral cancer in terms of sensitivity and specificity, then this will be the sequence. But you see the top two sequence are related to USG, and USG in practical life, if you see the interpretation of USG is different for different examiners. Like if you have a at one center they will find the node, at another center they can miss the node. So that is why CT scan, the third best option, have been chosen as a practical option, and this is the standard of care in today's day, like today's practice. So now at this point of time, for evaluating the neck in oral cancer patients, you have to do a contrast enhanced CT scan. So that is one test that will tell you about extent of the disease, primarily also, and also about neck metastasis. So I was talking about risk factors. So these are multiple risk factors, starting from staging of the tumor, differentiation of the tumor, like invasion type, whether it's the infiltrative lesion or proliferative lesion. Then tumor thickness also. Tumor thickness also matters in when it comes to neck metastasis. So and so on so forth. You can also see perineural infiltration, microvascular invasion. There are so many factors actually that can have increased risk of neck metastasis. So many authors, they tried to study this and tried to formulate a treatment protocol based on the risk factors. But you see, there have been so many studies, and the WISE study that you see first, it says that if the treatment risk is more than 20%, you have to do neck dissection in those cases. But the chart you see on your right is the chart that have been given in Weiss's paper to rule out that the risk is more than 20%. Now friends, you see that chart, and can you make out anything out of that chart? No, it's very difficult. So things were very personal, I think, for most of the authors, and it was very difficult to rule out that what are the risks of having neck metastasis, and when to do neck dissection, when not to do neck dissection. That is why all these studies, they were not followed up further, and we don't follow those rules at present day. So coming to story so far, we know that there is no good clinical examination that is foolproof. CT scan is one of the standard of care at present day. The risk factor assessment is not validated or user friendly. So whether to and how much to treat the N0 neck, that remains the question. So friends, that is the main question of today's discussion, that if you have a small disease, suppose this tongue primary I have shown, in this case, should you get away just by excising the lesion perorally, or you should also do neck dissection in these cases? And because the neck is clinically N0. So that's why we have got two schools of thought for management of neck in such cases. The first is wait and watch approach. This approach says that if you manage the patient just by doing primary and you don't address the neck, you can prevent another surgical procedure, and thereby you can reduce the cost that gets incorporated because of that surgical procedure, and also the morbidity that is caused by that surgical procedure. So neck dissection has got some morbidity, like in experts hand the morbidities are very less, but usually it have been seen that there is some deficiency in arm function followed by neck dissection. So that is why wait and watch approach, they propose these two things usually, that you can prevent the cost because of the neck dissection, and you can prevent the loss of like detriment to arm function. Now coming to elective neck dissection arm. They say that you do neck dissection at the time of primary surgery so that it will be a one step procedure, and it have been shown that elective neck dissection improves the survival in patients, and in experts hand the arm function can also be retained very much. So these are two schools of thought on which we will be further discussing. So what happened, why there was this need for this comparison of these arms? If you see the studies in 2003 and 2004, these surveys are showing, like the USA study is showing that 13% the doctors, they were observing the neck for angio cases, 66% were doing elective neck dissection, 19% were doing radiotherapy to the neck. And in the Europe study, if you see, there is no uniform therapeutic concept for treatment of cervical nodes. So that's why, because of so much variability among doctors, it was needed that there should be a consensus regarding this, that how to manage the angio neck. And to solve that issue, Tata Memorial Center, the study led by Dr. Anil Dikru sir, they did a retrospective study of their own patients, and they found out that there was not much difference between elective neck dissection and wait and watch approach. The study came non-significant. The p-value was not significant, but they suggested that because it's a retrospective study and because there is a equivalence it is showing, we should do a prospective randomized control trial. And from that day they started prospective study on this subject. And then in 2011, this was in 2009 and 2011, a meta-analysis again came that stated that elective neck dissection is better than wait and watch approach for angio cases. Again, there was a strong need for a randomized control trial. This is the landmark article, friends, that came in 2015. This article was published in New England Journal of Medicine, and this was the study done by Tata that they promised before. So this was the prospective randomized control trial they did in 2015, and they compared. They divided 500 patients into two groups, almost equal number of patients in each group. In the first group, they treated the neck at the time of primary surgery. In the second group, they treated the neck like after wait and watch approach. When in follow-ups, the patient came with positive node in neck, at that time they treated the neck. So these were two arms, very simple study. They just wanted a result that which arm is better, whether it's elective neck dissection or wait and watch approach. And they wanted to compare very easy things, like they wanted to compare a disease-free survival and overall survival. Disease-free survival, friends, is something where the patient is not, for how much time the patient is not having relapse. Okay, so they will set suppose a 5 year of time and check how many patients are getting relapse in which group. Okay, that is disease free survival. And then overall survival is how many patients died at that point of time, that is overall survival. So very easy study and very straightforward study. So let us see the results now. If you see the disease free survival, friends, you will find out that in elective neck dissection group, 81 patients had relapse, and in therapeutic neck dissection group, that is wait and watch and subsequent neck dissection, 146 patients had the relapse. And that is why there is so much of gap between these two procedures, and there is survival benefit of 23.6% in elective neck dissection group. Now coming to the overall survival, if you see, elective neck dissection group has 50 death and therapeutic neck dissection group has 79 death at the end of 5 years. So there is a survival benefit of 12.5% in this regard also. So they concluded in their study that elective neck dissection should be the standard of care for early node negative oral cancers. They also concluded that one death is prevented for every 8 patients treated with elective neck dissection. That comes from 12.5% of survival benefit, and one recurrence is prevented for every 4 patients treated with elective neck dissection. That comes from disease free survival benefit of 23.6%. So friends, this is the landmark paper. Whenever somebody asks you why you do elective neck dissection for N0 cases where there is no neck metastasis clinically, you have to quote Tata's article in that have been published in 2015. Further, in 2019, we had this article that is called Sent trial. In Sent trial also, they were comparing the same thing, and this study was going on in UK parallelly along with Tata. So in 2015, Tata's results came and that showed very significant results regarding elective neck dissection and some detrimental results in wait and watch approach. And that is why, as soon as Tata's study was published, the Sen trial was stopped. So they had lesser number of patients in their study. That was 250 randomized patients, and that is why they had added some 346 observational cohorts from 27 other hospitals in order to complete their results, and the results were almost same as that of Tata's study. It shows that disease free survival is much better in elective neck dissection than wait and watch approach, and the p value was highly significant. So this study again substantiates our previous results from Tata study. After the Tata study since 2015, we have total 8 meta-analyses published on this aspect till 2020. If you see, total 8 meta-analyses is there, and if you read the conclusion section, everywhere you can see that disease-free survival, overall survival was better in elective neck dissection group. Elective neck dissection reduces regional recurrences. Okay, odds of recurrence is significantly higher in wait and watch approach. It reduces the nodal recurrences. So friends, you can see in all these studies they have shown that elective neck dissection was always better than the wait and watch approach. Now few people say that the thinner tumors, they have less chances of metastasis to neck, and that is why they should be avoided. Neck dissection should be avoided in thinner tumors. Like this diagram you see is from the Jatin Shasha's book, and this was originally published in Spiro article. Okay, so you see that even if there is a lesser chances of metastasis in neck, there is some incidence of neck metastasis. It's about 13% of neck metastasis they have shown even in thinner tumors. And friends, it is very difficult to clinically measure the thickness of tumor. Okay, till date, whatever study they have done, they have tried to evaluate the post-operative histopathology results. Okay, so this is an important slide for PGs to know the difference between depth of invasion and tumor thickness, because in current AJCC staging of cancer, eighth this thing version, you see that depth of invasion have been included in the classification of in the TNM classification. So what is depth of invasion? The depth of invasion is the distance from basement membrane to the deepest point on the tumor front, and the tumor thickness is distance from the topmost portion of the tumor to the deepest portion of the tumor front. So depth of invasion is important, friends, because this thing can vary based on whether it is a ulcerative lesion or a proliferative lesion, but the depth of invasion is the important factor that matters. But till date, this thing have been talked on post-operative histopathology results. So there is just one study that studied this aspect, that whether the clinical findings and MRI related finding of depth it correlated with post-operative histopathology results or not. They found out that for thicker tumors, these values were correlating with the pathological thickness, that was a post-operative pathological thickness. But the for very thin tumors, that like they're less than 5 mm, you see, for less than 5 mm thickness, the clinical and radiological examination had low correlation with pathological thickness. So friends, the thinner tumors are the ones that are point of concern for us, because thinner tumors are the one where the logic of reducing the neck dissection comes, like not doing the neck dissection comes. And the thinner tumors are the one that you can't predict clinically, and there is no foolproof method of uh, detecting the tumor thickness clinically till date. And you see, whoever did the observational studies till date, like people whoever did wait and watch approach, uh, see, they have followed up the patients by USG guided FNAC, USG. Okay, so suppose these three observational studies that have been done till date, if you see if you see the outcome section, 9 out of 12 patients had extra capsular spread when they presented to the clinician. They were doing wait and watch approach. When patient came back to them, they found that 9 out of 12 already had the cancer out of the nodes. So that makes the survival very difficult. 4 patients died, 10 out of 12 needed adjuvant RT. Here you see 89% patients they needed mRND, and nodal relapse in 90.6%. 8 out of 10 needed R&D. So by observing this, you can see that if you do wait and watch approach, firstly the patient comes back with a bad relapse with extranodal spread, and also you have to do larger dissections. You have to do radical neck dissection, like you can't do supraomohyoid neck dissection or selective neck dissection. In those cases you will have to do radical neck dissection, and most of the patients they died, and many of the patients who survived, they also had relapse. So that's why friends, observational studies were a complete failure, and that is why we do elective neck dissection in all our cases. So because of this biological aggressiveness, elective neck dissection becomes mandatory over wait and watch approach. So few people asked whether a sentinel node biopsy can be done over formal neck dissection. To prevent neck dissections, whether a sentinel node biopsy can be done. So friends, sentinel node biopsy is a procedure which is a minimally invasive procedure. It allows surgeon to identify and excise upper echelon node. So what they do is they inject a radioisotope on the primary site. Suppose there is a tongue cancer, they will inject a dye in the tongue, and then they will evaluate the neck. If the dye comes in the neck at a certain lymph node, that means there is a metastasis in that lymph node, or that is the primary echelon node for that primary site. Then that node will be biopsied, and if the biopsy results come positive, you will go back and do complete neck dissection for the patient. So there have been two clinical trials comparing the sentinel node biopsy with the elective neck dissections. One study was done in Japan in 2019, and other study was done in France in 2020. So you see the Japanese study, they are showing there is no difference between two groups, and there is certain like if you see first and third month follow up, there is arm abduction was significantly worse in the neck dissection group. So they said that neck dissection leads to problem with the arm function, and otherwise both the procedures they have got equal results on survival and relapse free survival. Now see the other study that was published in France, and in this study also they compared neck dissection with sentinel node biopsy. They divided 307 patients for this study, and the results you can see, these are various outcomes, like relapse free survival, okay, loco regional relapse free survival, disease specific survival, and overall survival. In all the outcome parameters, you can see the results are almost same in two groups. But when it came to the arm function, these are the radar plots, friends. Radar plots, they the inner line you see is showing arm function followed by the sentinel node biopsy. The outer line you see shows arm function followed after the elective neck dissection. So these are charts drawn on various follow-ups, like second month follow-up, 6 month follow-up, second, fourth, sixth, and 12th month follow-up. So in the earlier follow-ups, you can see that the arm function is much worse in the neck dissection group, okay, and it is much less in the sentinel node biopsy group. But when it comes to 12-month follow-up, you can see the arm function is almost equal in both the groups. So now, given this equivocal result, given this equality among two groups, now other factors will rule out that which technique is better and which is not. So the other factors are that the learning curve with sentinel node biopsy is very steep. It's a newer technology. It is very costly affair, and it is not possible in resource constrained countries like India, and very few people are doing this thing till date. And it needs nuclear dye, serial step sectionings, immunohistochemistry. So procedure is very cumbersome, friends. And in sentinel node biopsy, you have, it's a two-step procedure. You have to do biopsy, and then it comes positive, then you have to do surgery, almost in a third of patients. So because of all these factors, it is preferred to do elective neck dissection, and that is why it becomes standard of care for N0 cases. Now friends, now we all know that N0 cases, you have to do elective neck dissection. But how much of neck dissection has to be done? Like what should be the extent of neck dissection, how many nodes you should remove? That is the another question. So friends, now we shall be going towards that part. So let us very quickly revise the anatomy. The level 1A nodes are located in the submental triangle. Level 1B nodes, they are located in the submandibular triangle. Level 2, 3 and 4 nodes are there on the along with the internal jugular vein. Level 2, 3, 4, and level 2 nodes are divided into 2A and 2B by spinal accessory nerve, okay. And that's why when you try to dissect the level 2B, there can be some damage to the spinal accessory nerve, and that leads to uh, detriment to arm function. And the in posterior triangle, you have got level 5 nodes, and the nodes that lies above the spinal accessory nerve are known as level 5A, and the one that lies below in the supraclavicular region are called level 5B nodes. So now coming to types of neck dissection, friends, that we have. This is a supraomohyoid neck dissection done. You see, this is the omohyoid muscle. When you stay above this, it is called supraomohyoid neck dissection. Here you remove level 1A from the submental triangle. This is the digastric belly, and you remove level 1B nodes. You remove level 2, level 2 and level 3 nodes. So here we removed level 1, 2 and 3 nodes. This is called supraomohyoid neck dissections. You go slightly below the omohyoid, that will also cover level 4 node. This is known as extended supraomohyoid neck dissection. This is the modified neck dissection. Here we have removed level 1 to level 5. Here you can see that we have also removed the nodes from the posterior triangle, but we have preserved the sternocleidomastoid muscle, spinal accessory nerve here, and also the internal jugular vein. So that is why it is a modified neck dissection. In modified neck dissection, you preserve uh, either one, two, or three of these three structures. Okay. In radical neck dissection, we remove all these structures like spinal accessory, internal jugular vein, and the sternocleidomastoid muscle also. This is example of another modified neck dissection where we have sacrificed the sternocleidomastoid muscle and the spinal accessory now. And friends, these structures are removed when the lymph nodes are actually encasing these structures, and you cannot like isolate the node from the structure. In those cases, you have to remove those structures. So that is why this is also a modified neck dissection treating level 1A to level 5 nodes. All the nodes have been removed. Okay. So now which one to do in N0 cases? That is the question. Now many people they say that supraomohyoid neck dissection is inadequate for tongue cancer, especially because there is a 15.8% of skip metastasis in tongue cancer. That skip metastasis happens at level 4. Like, what is skip metastasis? It is metastasis in level 4 when there is no metastasis at level 1, 2, 3. So that means there have been a skip of metastasis in that case. And this was originally told in a paper in 1997, very old paper by Byers. And based on that, many clinicians even today they try to treat level 4, I mean neck dissection till level 4 for all the patients, but that is not the case. We'll see that. Then can level 2 dissection be avoided? Friends, we saw that there can be some detriment to arm function because of damage to spinal accessory nerve. So can level 2b dissection be avoided? That was another question asked. Third question was, is it needed to go so below in the supraclavicular region? Like, should we remove the level 5 node? So that was another question regarding extent of the neck dissection. So we are going way back in time. In 1990, this study by Jatin Shah, this was a very retrospective study. It was a retrospective study uh, that showed that what they did was, at that point of time, only radical neck dissection was standard of care. I mean, reduced neck dissection were not done, but they tried to evaluate the patterns of neck dissection by examining their data retrospectively, and they found out that metastasis was found in 34% of elective neck dissection cases, the cases that were N0 clinically, and they electively dissected those necks, and they found that 34% of the patients they had neck node metastasis. But now come, let us see the pattern. In level 4, they found only 3% of metastasis. In tongue, RMT, and cheek region, there was no metastasis at level 5. And level 5 was involved only 1% of floor of mouth and gum primaries. So that is why, because there is no metastasis or very less metastasis at level 4 and level 5, okay, that these points they become the basis for the reduced extent of neck dissection. And further studies were pointed towards these points, that if this memorial slong catering study is showing such a less chances of metastasis into the lower level nodes, so can we avoid dissecting those nodes? So this is the landmark trial by Tata again. The study was led by Gauri Pantavaidya, and you see they did a very nice randomized control trial, and it was a prospective study, friends. They evaluated 583 patients, and they divided the nodes in separate levels, and they evaluated the patterns of metastasis. So now let us see their results. They found out that most of the oral cavity cancers they had metastasis in level 1 to 3. Okay, level 1, level 2, and 3. Like supraomohyoid neck was carrying most of the metastasis, and other levels were involved like less than 5%. So they said that 96% of metastasis happens at level 1 to level 4. So if you treat that much, level 1 to level 4, that is extended supraomoid neck dissection, friends, you will cover most of the nodal metastasis in N0 cases that can happen. Coming to skip metastasis, they did find some skip metastasis, but at level 3 and mostly in tongue cancers. Okay, so there was no skip metastasis at level 4 and 5 in the absence of level 1 to 3. Okay, so whenever there are positive nodes at level 2, level 3, then you can find a node at level 4, but else otherwise you won't find a skip metastasis at lower level node. Now coming to the factors that predicted level 5 metastasis and factors that predicted level 2b metastasis, because these were the questions we asked earlier, that do we want to treat level 2b, do we want to treat level 5? And if you see the results, whenever there was 2a positivity or level 3 positivity, okay, it showed level 5 metastasis present. Okay, and whenever there was level 2a positivity, that also showed that 2b was positive. So by this point you can think that whenever there is a, like, there is no need to do a modified neck dissection, no need to involve the level 5, level 2b, if there is no gross disease in level 2a, whether surgically or radiologically. So friends, if you don't find bigger nodes, like extranodal extension or clinically N0 cases, in those cases you can do supraomohyoid neck dissection, and you can also skip level 2b as per this article. Though I always treat level 2b also, and chances of arm function detriments are very less in my patients. So when you do some 50-60 neck dissections, immediately you will get a hang of it and you can actually do safely. So, but as per this study, it says that there is no need to address level 2b or level 5 if there is no gross metastasis in the neck. And this study was again supported after this Chinese trial. Okay, in this Chinese trial in 2014, you see, they also showed that there was no specific sorry, the disease specific survival was no significant difference between two groups. Like they compared supraomohyoid neck dissection with modified neck dissection, and there were fewer complications, there was good pain relief and good shoulder function in supraomohyoid neck dissection group, and it was safer to do supraomohyoid neck dissection. So friends, now you know the extent of neck dissection should be supraomohyoid. For N0 cases, you have to do elective neck dissection, and how much of neck you are going to treat, it should be supraomohyoid neck dissection. You should take out at least level 1 to 3, and in some cases you can follow extended supraomohyoid neck dissection also and remove level 1 to 4. So this slide is slightly apart from today's topic. Here they are showing that whether selective neck dissection can be done for positive necks also. So this was a meta-analysis by Rodrigo et al, and they analyzed that if you are doing a selective neck dissection like supraomohyoid neck dissection in N1 and few N2 cases, like very selected N2 cases, you can actually do this and it is good. So but the patient should not have any adverse features. Okay, the primary should be T1 T2, and regarding node, the node should not have extranodal extension. There should be absence of palpable metastasis, and it should not be a very large volume node and all those things. So for very early N plus cases also, very early N1 and N2 cases also, selective neck dissection can be done, friends. But whenever there is a bigger nodes, palpable nodes, in those cases you should do modified neck dissection, friends. There is another question, that when should you treat contralateral neck also? Suppose left side of tongue is having a cancer, you have to treat left side of neck. but when should you also treat the other side of neck? So the general consensus is whenever a cancer is reaching to midline or crossing the midline, you should do bilateral neck dissection, and that is the standard of care in today's day also. So this study, they were predicting that when you should like give adjuvant to opposite neck also. So they found out that the contralateral metastasis was present in 29% of tongue cancers, and of these 97% had ipsilateral metastasis. So ipsilateral metastasis is the should be the rule of thumb. If you have a metastasis in the ipsilateral neck, in that case you should also give adjuvant RT to the contralateral neck. I hope you all are getting this thing. So we are slowly coming to end of our slide. So, and there is a confusion to people regarding single node positive. Whenever there is a small disease like T1 T2 disease with one node positive in the neck, should you give radiation to this patient or not? So this is a paper from ASCO guidelines, and they have ASCO is a American Society for Cancer, American Society for Clinical Oncology. So they have recommended that for a single node positive case, you should not give radiotherapy. Okay, until and unless there are adverse feature associated either with primary or with node. Adverse feature related to primary are perineural invasion, lymphovascular invasion, or T3 T4 disease. Okay, and adverse feature related to neck are extranodal extension, these things, or big nodes. In those cases you have to give radiation. But if there is just single node positive, you can, and without these adverse features, you can actually avoid radiation in those cases. So now I'm coming to my last slides. Few people ask that what should be the quality of neck dissection. So a surgeon who can dissect at least 18 nodes from the neck, these numbers you get after your post-operative histopathology results. They will tell you how many lymph nodes they got. So if they say that you have more than 18 nodes, that means your neck dissection is okay. I mean, that is the minimum nodal yield that one should have in terms of quality of neck dissection. But today I see most of the surgeons, most of the maxillofacial surgeons who are doing neck dissections, they are getting more than this basic threshold level. Okay, we get 100 150 nodes in our neck dissections. So this is the for a like exam very important point. In many studies they have proven that 18 lymph node is the base level, and that defines the quality of neck dissection. If you are dissecting lesser than 18 nodes, the chances of relapse and chances of decrease in survival will be there. So conclude friends, it is preferable to treat N0 neck, and you should logistically do supraomohyoid neck dissection. Sentinel node biopsy has its place, but there are a lot of limitations. Level 4, level 5, and level 2B should be addressed in very advanced cases. Okay, level 1 to 3 is sufficient for most of the early diseases like T1, T2 with N0 cases. The quality of neck dissection is important and based on the node harvest and nodal yield, friends. So thank you so much for your patient listening, and now we can go on to the questions.
Thank you so much, sir.
Now I would like to invite Dr. Akshay Daga sir, Professor, Department of Oral and Maxillofacial Surgery, to propose the vote of thanks. Over to you, sir.
Dr. Mishra will take over for the moderation. Dr. Ram?
Thank you so much, sir.
Dr. Ram? Dr.
Now
Mishra
I
will
would
take
like
over
to.
the dais for the moderation. Dr.
Okay.
Mishra? Dr. Mishra?
Yes. Yeah. Hello, Manish. Can you see
Hello,
me?
hello sir, hello sir, good afternoon sir, कैसे हो
How are
सर?
you, Manish?
बहुत
And it
अच्छा
was
हूँ सर, आप
wonderful.
कैसे?
It was wonderful listening to you. I was
Thank you
listening
sir.
to you throughout, and extremely proud of you personally myself. That I've always been, telling all my students that uh, how such a wonderful PG student we had in you, and I always keep on giving your examples, Manish. Okay,
Thank
so
you
it
sir.
was
Thank
very wonderful to listen to you. It was a very very clear presentation for everyone at all stages. Even the your presentation was as clean as your dissections, which you were showing. I mean, it was wonderful. Uh, I have a list of questions which the PGs have given it to me. Uh, I'll just read it out for you.
you. Yes.
One of the questions which has come as in skip metastasis, that is level 2 to 5, is there a need to dissect further to 3 and 4 also? This is a question which has come from one of the PGs. And one more question which has come up is what should be done in the maxillary or mid-phase malignancies, those that have crossed the midline. I mean, we are talking about the mandibular and the FOM malignancies, those who have crossed the midline. But what should be the approach of the palatal or maxillary malignancies, which are showing signs of crossing the midline with a node negative or showing a subcentric invasion? So I
Right,
would like to hear your comments, Manish. And on a
right,
personal note, I would also like to add, because we have a mixed audience over here on the occasion of OMFS Day. I would like you to orient our beginners and our younger population of doctors, that is interns and beginner MDS students, to enlighten the role of a dentist and an early max-fac surgeon towards diagnosing and their approach towards such cases. Over to you,
right,
Manish.
right. So coming to the first question, yeah, it is very well known that there is a skip metastasis. There can be some skip metastasis, but you get to know in most of the cases you get to know that only after post-operative histopathology results. So once you have given the neck dissection specimen to the pathologist, then you get to know that there is a skip metastasis. Okay, most of the time in N0 cases, as I told you, like in 20% of the cases almost, you can miss any nodal metastasis in cases. So yes, you have to dissect level 1 to level 3, even if there is skip metastasis, or you clinically find out that there is a skip metastasis. And in case you clinically find out there is a skip metastasis, that means there is a more than 1 centimeter node, that is a enlarged node at level 4. In that case you should do level 1 to 5, that is a modified neck dissection, rather than only doing level 1 to 3 or 1 to 4 in those cases. So that answers the first question. Yes, we do bilateral supraomoid neck dissection for uh, upper jaw cancers also, that crosses midline. We believe that upper jaw cancers, they usually drain to submandibular nodes. So bilateral nodes should be dissected for cancers crossing the midline in those cases also. And now coming to the third question, yes, like as a dentist, see, I completely believe that oral cancer is going to be maxillofacial surgeons niche completely, because we are having our dental colleagues along with us, and dentists are the people who are regularly screening people's mouth. But the only problem is they more focus on like the hard tissues rather than the soft tissues. Whenever a patient comes to dentist, they will start finding caries, start finding the edentulous areas. Okay, what they can do about it? But they should also look at the soft tissues. Like a dentist should always look into the buccal mucosa, the tongue, the palate, and all those sites. And it is very easy to define a normal area, normal mucosa with a abnormal mucosa. And as soon as you find a abnormal mucosa, you should start following up that patient. Never take any leukoplakia, erythroplakia, or submucous fibrosis lightly, because these are the things that will get converted into cancer. Cancer doesn't happen immediately. It happens after several years of having a pre-malignant lesion in mouth, and then it develops into dysplasia, and then that develops into invasive cancer. So friends, whenever you see a pre-malignant lesion, you are having the best chance to save that person's life. If that pre-malignant lesion is looking suspicious, in that case you should do a biopsy, and you should rule out whether there is any dysplasia present or not. And based on the grade of dysplasia, as you all know, we have uh, grades of dysplasia, and if it comes as a high grade dysplasia, in those cases you should try to excise that lesion there and there only. Okay. And if it's a low grade dysplasia, in those cases the patient should be followed up for very long. Okay. You should tell the patient that you have to visit us every 6 months or every say 3 months for follow up. And as soon as there is an invasive lesion starts in that pre-malignant lesion, you should immediately excise that lesion, and that will save that patient's life. Because cancer, it grows silently, and it shows up at very late stages, when the disease is grown to T4 level, then the patient feels some pain and some discomfort. So that's why friends, dentists, they are the main person, they are the key person in saving patients with oral cancers. Yes sir, I think that answers the question, right?
Yeah, excellently submitted, Manish. I would, give a same word to all the interns watching over here that, we should be proud of our MaxVac oncosurgeons. We have a brilliant oncosurgeon in Dr. Manish over here. And because most of the beginners, they don't understand whom to refer such cases to. They are usually the first ones whom such cases come to. Those having a small tumor with a node negative neck, or, something, the initial cases. So I think it is very important for all the beginners and for the dentists to orient themselves and to refer such cases to a consultant oral and maxillofacial surgeon. So I again thank you, Manish, for your excellent early summation of all the answers. I hope that they were clear for everyone. I have one more question just coming in. If you have a few minutes more, Manish,
Right.
is it indicated to sacrifice both IJVs if bilateral tumor invasion is seen? This is one of the questions coming from our third year PG. That is it
Right.
indicated to sacrifice both IJVs if bilateral tumor invasion is present? I think
Right.
this is the last question for the day, and then Daga sir can take over from me.
Yeah. In these cases, sometimes we do that, but that has to be you can actually stage the neck dissection. In these cases, you can do ipsilateral neck dissection, remove one IJV, and wait for some days, and then do another neck. In that case, body will first adapt itself to it will start its collateral drainage channels on the ipsilateral neck, and then you can go on contralateral neck and remove another IJV also. But yes, if the IJV is involved both the side, you have to remove it. But I think staging of the neck dissection can be done in those cases, in order for body to take time and accommodate to these changes in the venous drainage.
Yeah, thank you, Manish. I hope the concerned PG has got the answer. I would now like to pass it on to Daga sir. And one last token of appreciation for you, Manish. I think
Thank you
what you
sir.
can already see on the screen,
Yes sir,
and
thank you.
would definitely get back to you after this session. All the very best, and keep continuing your great work. Thank
Thank
you
you
for
sir,
being with
thank you so
us.
much.
We miss
Nice,
you
nice
wholeheartedly.
seeing sir.
Okay, and nowadays there is a big song, which is very famous, Manish.
Yeah.
This is personally for you. That there is a song nowadays, "Bachpan ka pyar bhul nahi jana." So that is
Never sir.
specially for you. Okay, okay. It was
Yes
lovely
sir.
to have you, Manish. Thank you.
Lovely talking to you sir.
Thank you, Manish. Thank you.
So, Manish, it was a great talk. Fantastic to hear from you. And you can see that having over an alumnus of the college is always very heartwarming. The kind of camaraderie Dr. Mishra and all the interns and the PGs share with you cannot be shared with any formal guest who's not from this college and who's not seen, who's not grown into what he has right now, had not been this college there for you. Getting your fellowship done with Saidul Islam sir itself is a great achievement, and I am really thankful to you for enlightening all of our PGs, interns, upcoming budding maxillofacial surgeons, and hopefully a few oncosurgeons, to give them such a beautiful insight about such a valid and important topic. I also congratulate you for your new job, which you are starting as an oncosurgeon in Mumbai soon, and wish you all the very best from not only the department, but from the whole college and from our honorable president, sir. Thank you for sparing your time and enlightening us on this oral and maxillofacial day.
Thank you, sir. Thank you.
Thank you, sir. Now I request Dr. Shalu Bansal, Professor and Head of the Department, to present a certificate of appreciation to Dr. Manish Tiwari, sir.
Hi Manish, I think it is already projecting since a few minutes back. This is a small token of appreciation and we are really thankful. And I can easily say everybody was happy that you are going to be there with us, all the postgraduates. And it's a good bond. Thank you so much for sparing your time. Thank you.
Thank you. Thank
God
you,
bless.
everyone. Yes.
Thank you.
Bye-bye.
And that certificate I will mail you shortly. And thank you everyone for being with us.
Thank you.
Thank
Thank you,
you.
ma'am. Thank you, everyone.
Thank you, one and all. Have a great day ahead.